Hello everybody, are we audible?
Yes, you are.
Yeah, thank you very much and good evening to all of you. And some lovely sessions in previous 3 days with TCT India. I think it's a privilege to be here presenting this live case from Medanta. I'm joined by my full team. He's Dr. Himanshu Dabral, Dr. Saqib, Dr. Tejbir. So all of us are showing this live case from Vedanta. Uh, so thank you for having us here. I'll start with the historical aspects of this case. Dr. Saqib, can you go
Yeah.
through the slides?
So this 60-year-old gentleman, a known case of type 2 diabetes mellitus and a known case of coronary artery disease, presented to us with chief complaints of angina on exertion, NYHA class 3, and dyspnea on exertion, NYHA class 3. On 8th of July, this patient had a sudden onset chest pain for which he sought a medical consultation at peripheral center, and he was referred to the Vedanta and diagnosed as ACS. So next slide, please. On arrival at Medanta, we did a 2D echo which showed akinetic LAD territory with LV ejection fraction of 25 to 30%. Subsequently, coronary angiography was done which revealed triple vessel disease, and then cardiac PET was done which showed some hibernation in the LAD territory. So based on these findings, patient was advised to go for CABG, but in view of comorbidities and refusal by the patient to go for CABG, he was planned for multi-vessel stenting with stenting to RCA, bifurcation stenting in the LCX and OM, and stenting to LAD. Now
I think the plan would make sense once we show you the angiogram. So can we have the angiogram? Yeah. So this is the angiogram which we have done 2 days back. As you can see, the right coronary artery is very critically narrowed in the proximal segment, and there are significant collaterals, filling up the septal branches of LAD, and almost it seems that LAD must have occlusion in the proximal segment because there are good collaterals reaching to that segment of LAD. Next one. So these are all RCA shots. Yeah, next. 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 Okay. And this is the left system. So it's extensive disease. Next. Okay. Next. Okay, so this is LAD, 99% subtotal occlusion. There is some thrombus in the mid segment, and the distal segment is very faintly visible. TIMI 1 flow. Come back, 1. Yeah, and this is RAO caudal view, also showing us there's a significant and critical disease in the circumflex also, and the upper obtuse marginal is also ostially narrowed, plus there is a critical narrowing in the circumflex also. So I think that also makes a good bifurcation lesion in the circumflex, and LAD is, as I mentioned, is subtotal occlusion. So as far as history narrated by Dr. Saqib, I think this patient had anterior wall MI about 20 days back, and now he landed up with heart failure few days back with us. So we stabilized this patient. On echo, LAD was fully akinetic. We went ahead with the PET cardiac. It showed a significant hibernation in the LAD. We discussed all the options with the patient and patient's family, CABG, as it's a triple vessel disease, extensive disease, but at no point family was ready for surgical intervention. So we are all here, and also we discussed with our surgeon, since LAD was akinetic and EF of around 25%, they were also not very keen going ahead with that, but since there is a hibernation, we are all set to show you the revascularization plan. So can we have some inputs from the panel here, and then we show how do we plan and how are we going ahead?
Well, that's an excellent case with a lot of points of discussion. One of the key things here is what are the hemodynamics of the patient, like a right heart cath, cardiac output, and whether it has a presence of a thrombus in the LV, and what the peripheral vasculature looks like in case you need support. That's part one. The second thing is whether you're going to do most of the revascularization in one setting, Second is what areas are viable, and if you're going to stage, how you're going to start. So I will pass it over to Sanjog just for a very quick comment so that we can let you work, because that's the most important part of the life case, not us talking, but you doing the work.
Yeah, no, nice case. I think a patient who has demonstrable indication for revascularization with all of the salient points that were brought up by Dimitri a few moments ago. I guess the question that comes to my mind, beyond all of the points that Dimitri had just brought up, is depending on the hemodynamics. If the hemodynamics are deranged at the beginning end of the case, so you put a right heart cath up and you define that the cardiac output is poor, but the pressures are high, do you stop? Do you take the patient off, optimize? Or do you go ahead? Are you going to use mechanical circulatory support, or is it, a secondary access when doing the case? And then are you going to start with the LAD? Because arguably, if it's already hibernating and you're not encumbering anything, you're not going to have much in the way of injury to the myocardium if you get into trouble. You're going to go after the RV first, or the RCA first, because it's arguably the biggest bang for your buck and gives you the biggest backup.
Yeah. So I tell you about the hemodynamics. The patient had been clinically stable for last few days, although we have been diureting the patient and getting him decongested. At X-ray showed mild congestion. Pressures were okay. There was no tachycardia. As per plan of revascularization, as Dr. Sanjog just mentioned, we went ahead with the RCA first, as it's a very simpler lesion, and we have already stented that. I'll just show you a few shots of that once we have done a RCA stent, but I think nothing eventful in that. So RCA stent has gone fine, and it's okay. But about doing the LAD first, we also thought that, but sorry, I haven't shown you a spider view. Can you show a spider view? There is an osteal involvement of the LAD also. Yeah. So LAD osteally is diseased. So now what we have done, after stenting the right coronary artery, we have wired the LAD, dilated the LAD with balloon 2015, and established a perfusion into the LAD. And then we plan to go ahead with the bifurcation circ. As you know very clearly, if we stent the LAD, there may be half a strut into the left main, and we may face difficulties getting the hardware into the circ. So that is the plan. Please show next. Now the procedure. So I'll just show you that how does the perfusion look like after we have dilated the LAD. This is the RCA stent that has gone in uneventful. I'm not interested in showing this. Next. Please go next. Okay, next. There was slight issue wiring the LAD at one point, but again nothing, not a big effort. So wired the LAD, then wiring the circ, then dilated the LAD to maintain a perfusion. Next. Okay, so this is that balloon dilatation of the LAD is not visible, but I'll show you how it looks after the balloon dilatation. So then we wired the circumflex. As I mentioned, because of the osteal involvement of LAD, we do plan to put stents into the circ and do the bifurcation stenting here. So wired both and then dilated with the Wolverine cutting balloon Boston, the osteal of obtuse marginal first. This is 2.5 into 12 Wolverine, and we have done the cutting balloon of the osteal obtuse marginal first, and this lesion also into the circumflex. Next. So this is how it looks now. Next, show the LAD also. Yeah, this is how the LAD looks. There are good septal branches, although on echo it looks akinetic, but I think there is a significant hibernation in this area. So this is where we are at the present moment, and we do want to showcase the bifurcation stenting, that how do we plan for the circumflex. Okay.
Dr. Rajneesh, this is Aditya here. Hi, good evening.
Hi Aditya, yeah.
Hi, and hi Sanjog, good evening. So
Good evening.
I think that's a great strategy because doing the RCA first is not a bad idea at all. It's a simpler
Come
lesion.
back
I
one.
just wanted to ask you quickly: is there some disease in the ramus as well? Because
Yeah,
I
there is.
don't
There
leave
is.
the ramus alone. I guess
There is some disease in the ramus also.
probably you will leave it alone.
Yeah, that's what we are still
Great.
thinking that whether to touch that or not, because it's quite complex otherwise. And
Yeah,
we
yeah,
know the guy's LV function is
yeah.
25%.
Don't want to
So yeah,
overstep.
yeah,
Yeah.
yeah.
So we look
So
forward
Keeping
to.
in mind there's arguably no reason to do everything all in the same procedure, right? Within
Absolutely.
contrast
2.5,
limitations,
30
radiation limitations.
onyx
Particularly, it's interesting,
and
this whole
3,
concept of multi-vessel PCI in the
312.
context of poor EF, in our experience,
2.5,
whether you're
30.
on support or non-on support, they go in with an ejection fraction of 20%. And by the time you have IVISed and optimized and taken high pressure balloons up, you walk out with an ejection fraction of 15% or 12%. And that's directly indexed to the number of
2.5, 30.
vessels that you're doing and how well you're hemodynamically optimized at the beginning. So you can make the argument that if the ramus is certainly diseased, but there's nothing in front of it, and your bifurcation stenting is limited to the circumflex territory, or you're going after the LAD and you've done the right, then there's nothing wrong with keeping the guy in hospital for a couple of days, bringing him back, staging the other two vessels. If you're on support, it's a slightly different discussion, I think. Any thought to have been putting up a right heart cath and monitoring the pulmonary pressures during the case to try to define whether or not your hemodynamics are changing?
I think yes, it's a nice thought, and we all think of that. And so, given that we first check the echo with the IVC and pressures of the right side, there was mild TR. So PA pressures were 30 to 35 at the time of starting the case. So yes, it's in our mind. We have lines ready, but not at the moment. We haven't gone ahead with this right heart just prior to this case. And next show. Come caudal, please. Little more caudal.
Actually, coming back to Sandro's point about multi-vessel
Check.
PCI and how hemodynamics
Okay.
change
Let's
during
have
the
the other one.
case. We
312.
recently launched under Greg Stone in the US the Protect 4 randomized trial, which is going to answer a lot of these questions, like whether you have a CP impella in with or without right heart cath, and there are several sub-studies on it. Is going to make a difference. It's a strategy trial. We've already enrolled 3 patients, and a lot of these questions, hopefully within the next 5 years, will be answered. Right now, it's pretty much just a judgment call.
So I agree, having a support is always good, but somehow the financial constraints still exist in India with some patients. So we were unable to take that call. But yes.
Yeah, it's not to suggest though that for this case you have to have hemodynamic support. I don't think that's what's being suggested at all.
Yeah, I got
because
it.
the lesions themselves are straightforward.
Check.
What I
Go
said,
ahead,
Sandro,
Dimitri,
is that there is equipose.
Agreed.
And that's why we're doing a randomized trial,
Yeah.
right? To answer these questions. I'm not suggesting that it should be
Stop.
done one way or the other. I'm just saying it's an unanswered question.
Stop.
Yeah, completely agreed. I think that was the point that I was about to make as well. Is that one is not suggesting that that you need hemodynamic support. I think what we are suggesting, based on clinical experience, is that you need a good understanding of the hemodynamics before you go into the case.
Go Elio. Yeah. So this is what we plan. We just plan a mini crush here, the bifurcation of circumflex, and we are in with both the stents. So the longer stent we are planning to be mini crushed with the shorter stent into the obtuse marginal. Check.
So this is a classical mini crush, as opposed to doing a rewire and kiss before you crush with a stent.
Check. Okay, go on the longer stent, 2.5. No, this one. This one, yeah. Huh?
This is one.
Huh?
ये नहीं.
This one. Okay, just check. Excellent.
Dr. Kapoor, did you perform intravascular imaging in any of the vessels before your stenting, or just to assess the size of the vessels and whether you actually need to do a bifurcation stenting?
We do.
Sometimes
we do plan to use imaging, but as I mentioned, there's a LED infarction, EF is down. So we want to open the vessels first, and after stent, I think I'll show you the imaging part. I'm sorry we didn't use it prior because of the slightly borderline hemodynamics, although it's okay, stable, but still, with the recent infarct and, okay, go on this 2.5. Yeah, go up. 6, 8, 10, 12, 14, down. Come in this area caudal. Check. Okay.
I guess the challenge without intravascular imaging here is the stenting strategy that you've chosen. There's a pretty good going size mismatch between the proximal part of the circumflex
go up again
and that branch.
on the same,
right?
on the
So
same.
depending on what your
10,
stent strategy and your stenting
14,
platform
16.
is, you've got to make sure
Down.
that you can actually expand your proximal stent to address the size needs of the proximal circumflex as well as into that first OM.
Check. Okay, so this is one stent we have adequately dilated. We're going to take this wire out. Okay, let's now fix the other stent. Check. Okay, give me caudal, please. Okay, keep it here, keep it here. Come back. Yeah. Caudal. Okay. Yeah, I agree. There is a discrepancy in the size here. The proximal circ looks much bigger. And so we have taken a 3O stent here, although I was thinking 2.75, and we do plan to just deploy it at a lower pressures, 5 or 6 atmospheres, and then dilate it inside. Check.
And what's the platform of stent that you've chosen?
Onyx. Both the stents are Onyx. So they have good expansibility, we know. Go up. 4.
Actually, for the audience, that's a very important point because you need to know
6.
what stent you're using because not all stents can
down.
be post-dilated to the same degree. So it's critical knowing which stent you're using.
Yeah.
Because, for example, a 2.5 Zions will not go to the same size as, for example, a 2.5 Synergy. So you really need to know how much you can expand your stents.
Yeah, so I think with Onyx also we are pretty comfortable that it can go up higher in size. The 3 can go up to 4 easily. So I don't think that problem is with Onyx. See, this is how it looks once we are deployed. So still I agree that proximal circ looks almost 3.75 to 4. So this is, but now we are going to dilate it inside with 3 first at a higher pressure than 3.5, and now I think I can show you after dilating it with 3.5 in the proximal circ, I can show you the OCT picture of this place, and then go on to do the LED stent.
What is the creatinine of the patient?
Creatinine is normal, it's 1.0.
Yeah, I think the case of going, I think that the description, at least on this side of the world where intravascular imaging is used, is typically pre-PCI to define your landing zones, define your stent size. And I think arguably,
come this side.
Once you've done your stenting and you've actually put balloons up in these low EFs, you've achieved the stunning of the myocardium that you're worried about. So at that point, putting more gear down the vessels, I think, it depends on which side of that equipoise argument you sit on. You could argue that it's actually more hemodynamically protuberant to bring the devices down after the stents are in because you've already irritated the heart. But the main point that was just made by Dimitri, I think very nicely, was that if you're going to choose afterwards to do your imaging, you have to make sure that the stent platform that you've chosen has expansibility enough so that even if you're wrong, you have enough play within the stent sizing to be able to get appropriate stent expansion proximally. Because we know that one of the #1 reasons for poor outcomes in what we do is we choose stents that are too small.
The other comment I would make is that in a case like this, I would personally not use OCT. I think OCT is a phenomenal imaging modality. But someone who is hemodynamically compromised and we're giving contrast, adding 20 or 30 more cc's of contrast is probably not the most prudent thing to do.
I agree with this aspect. You know, obviously OCT requires some more contrast and a high pressure injection into the coronaries. So we also thought of that, but somehow our IVUS was not fully functional today. So OCT is right in place.
Okay,
And
so end of argument then.
after this dilatation, I'll show you the OCT. Go up. 6-8.
Like I'm getting a message from the
10, down,
organizers that
down.
the other live case is also ready. So we can either switch over there for a moment, or if you think you're going to do the intravascular imaging right away here.
Right away, I think I just require 2 minutes to show you the OCT. We're ready with that. Okay, show me this. Show this stent boost. Okay.
You're going to recross and do your kiss, right, Dr.
I'll do that. But
so why don't we move into the other case?
Okay.
And,
You can
then,
do that. You can do that.
And then you recross. You do your final kiss. You're probably going to do a pause before recrossing, and
Yes,
then we
yes.
can have a more comprehensive idea of what happened.
Yeah, that also is
That's a
fair.
great
That
idea.
also is fair. Yeah. So we'll tell you how we have done the next steps. Please show it from 4 or 5, views back. Please show. So we recrossed the wire, did the kissing. After doing the pot and after the kissing, we have taken the OCT image, which we are going to show it to you. Please show. Come back. Come back. Come back. Come back. Come back. Yeah, please more further back. Further back. One more back. Yeah. So this was here. Once we stented, I did the pot with 3O balloon at 22 atmosphere for the proximal edge, and then recrossed. Next. Yeah. So this is a wire recrossed. Next. And then this is a kissing with 2.5 into the. This is a 2.5 10 balloon, and then that is a 3 balloon. So at balanced pressures, this is a kissing done. Next. And then can you run the OCT image, Gaurav? So after this, we have done the OCT. Yeah. So is it visible? OCT is visible on your screen?
Yeah, we can see it. Yeah, we can see it.
Yeah. Come back. Keep coming back, Gaurav. Okay. So this is the distal edge. A very minor dissection at 2 o'clock, but I think it's very small, and it looks well opposed, well expanded, and this is the lumen of the other branch across through the strut. Yeah. Next, please come back. And here also, where the vessel was looking bigger, it looks well opposed. So after the pot, and this is the final. Yeah.
What was the balloon size you used to pot proximally?
3O balloon at 22 atmospheres. I was thinking 3.5, but then visually it was looking good. The balloon dilated in that segment. So now OCT.
So you have your OCT. So what is what's your diameter from external elastic lamina to external elastic lamina?
The proximal segment diameter of the stent. Yeah, here. No, slightly distal.
Ultimately, we know that it's not really the apposition that we worry about acutely, right? It's the expansion. It's making sure that we make the stent as large as we can. So if we're, that's right. So 397, right? So you have some room to make that bigger.
3.57.
Right, so you still have some room to make that bigger, particularly given that OCT discounts the size in comparison to IVUS, right? It's systematically undersizes.
Yeah, I agree.
So, do you think it's reasonable to take a 3.5 balloon?
We can do that. 3.5 balloon, 3.5 balloon, and the same 2.5. 3.56. Yeah. And then after this, I think we'll tackle the LED. So as I mentioned, we have to start from the ostium, but I'll give you a kissing balloon with 3.5 and 2.5 balloon. You know what's happening. So it's not only 3.5 with the 3O balloon with pot. We have also given a cumulative 2 balloon dilatation. So that is probably that's the reason it looks well opposed. But I think we can do 3.5 and then do the kissing again. Have the two balloon again.
I mean, if you look at the sort of more contemporary bifurcation data, they will suggest that you do a final pot after your kissing balloon inflation to make sure that your proximal vessel circular, right? So if you've done a kiss now and you're satisfied with your kiss, what's left is the proximal pot with your 3.5, right?
I hate to disagree with you, Sandrik, but I don't buy into this final pot. I know there are some serious studies and so on and so forth that if you make it circular, you may have some advantage, but I'm not really convinced. So I don't routinely do a final pot. I think the most important thing is to do a pot before you recross, so that you make sure that that you recross at the right spot.
Show the
you know, Dimitri, for what it's worth, I never used to do that proximal pot as well. It's been real great working with Vlad Javik here, who's a bifurcation expert, part of a lot of those larger trials. And what I've noticed with him on imaging, when I have not done the proximal pot, it's not so much that the stents aren't opposed; they look great, but that there are stent struts that are pointing downwards into the lumen between the joint point of the two balloons. I don't know if that makes a difference because the minimal lumen area is pretty big, right? But I've convinced myself that if you don't have that and you can create that with a single balloon that you probably have open already on the table, there's nothing wrong with doing that.
Okay, go on 2. 2, 4, 6, 8, and 3.5. 2.
Although for the record, that's not as visible on IVUS as it is on OCT.
3. Down. So we have done both the steps. So I agree there is some debate that to end with the final kiss. So I've done pots and then the final kiss. Pot again done with 3.5 at 14 atmospheres, and then the kiss again with 3.5 and 2.5. Please show the kiss again. And now I'll show you the angiographic view. May not do the OCT again. So it was not apposition wise, it was not, I won't say that we found a malapposition, but still I think as the vessel size was looking greater, so we have done it. The reason I said, although we have done the pot at 3, but cumulative balloon inflations might have attained that size which we wanted. So this is the final picture of this bifurcation. Yeah, I think it's looking pretty clean, and I hope all of you would concur with this. And now I'm taking the wire out.
So you've done the right now, you've done the circumflex bifurcation. How much contrast have you used? How much radiation are you at? What are your hemodynamic indicators right now?
So can anybody tell the radiation part? Contrast is right in front of me. I think we have done 120 ml, 120 ml up till now. Somebody can give an answer on the radiation part?
Radiation 6449 milligrays.
20.
Sorry, did you say 6449 milligrays? So 6.4 gray?
Yeah.
So 6.4 gray is a fair amount of radiation, particularly when you've... That's a massive amount of radiation.
That's a lot of radiation, and you've been working in the same view,
a similar
part of the bifurcation.
Okay.
Dimitri, can you comment on sort of what the guidelines are in North America when you cross 5 gray?
Well, there are no really guidelines. I mean, the less you use, the better. The issue here is that once you get at 6.4 gray, and with modern equipment, you can actually map the radiation entry zone into the skin. But 6.4 gray is a lot of gray.
Yeah, that's a fair amount of radiation in one spot.
Yeah.
We had a
That is 32.
mandatory report protocol actually where we had to do
32.
follow up for
2.75.
radiation skin injury at
30,
any point
30 is fine.
beyond
13 चल
any
जाएगा.
point beyond 5 gray.
Onyx.
Yeah, of
And
course,
then
of course, we have the same protocol as you remember,
Yeah.
but it's not like a strict hard.
no, the hard cut I think in the States defines 10 gray as a sentinel event, which for the audience is the same thing as cutting off the wrong leg if you were to do a surgery. So
yeah,
so 6.4 is more than halfway there.
yeah, and the issue is that it changes. It differs from state to state and from country to country. So people who perform complex PCI need to consult with their physicists and make sure that they know the exact limits of what constitutes a sentinel event, because it's a big deal.
Wait, they die.
Yeah.
Not only legally, but for the patient as well.
Yeah. There's a series that's, or a paper that was published by Steve Balter at Columbia, whom obviously we both know very well, that documented the nature of a radiation skin injury following a 10 gray procedure. And you see those pictures once and it's humbling. You know, the patient described it as the feeling of someone putting a hot baseball bat to his back all the time. So I think it can't be overstated how important it is to make sure that the radiation is watched very carefully.
Now, the other issue here, besides the radiation, is whether you do a crossover or you try to nail the ostium. And in all honesty, I think that's where intravascular ultrasound is of paramount importance. And personally, I'm not trying to nail ostium. I'm just doing a crossover if the ostium of the circ is normal.
Absolutely agreed. Exactly the same thing I do. I think if you have a landing zone that you can define by intravascular imaging, that's fine.
6, 8.
Otherwise, I
10,
think there's little tax to crossing over into a left main and making sure that the stent is EEL to EEL sized.
And we also know that if you have ostial LAD disease, in the vast majority of cases, the plaque extends into the distal left main. So the patient may come back 6 months from now and with restenosis, in segment restenosis in the left main. So I think it's not worth wasting time, radiation, and contrast if you have good information from intravascular imaging to just do a crossover into the left main.
So while the important discussion is going on radiation and radiation protection, I think I'll stick to my case. We have done a LED stent also starting from the ostia. Can you show the views? Yeah. So previous view, previous. So this is the positioning. Next. Yeah. So next. No, come back. Next. Yeah. So this is the stent deployed right at the ostia. I think hardly any protrusion, very minimal into the left main, but we have well covered the ostia and AP cranial view. Next. Okay. This is how it looks. We are on to going ahead with the post dilatation with 3O balloon. Right. We have taken a 2.75 based on the distal sizing.
We'll let you do that and do the imaging post while we move over back to Dr. Pratap at column.
Sure.
I think they're back up, and we'll see you then. Looking forward to your final result.
Yeah. Hi, Sanjog. So we are back again.
Hi.
Yeah. So I'll show you. We have done the post dilatation of the LED stent and have taken a OCT run. So can we run a OCT video here? Yeah. So this is the OCT video of the LED stent. Yeah. So looks good here. Again, well opposed. It looks reddish, in at this segment, but there is some ectatic segment, and we calculated the vessel was 3.5. So we have dilated after that, which I'm not showing. So after this OCT run, we have dilated with 3.5 at around 16 atmospheres, and we're coming back. And see the ostial placement. It looks pretty good. Just half a strut into the left main. Yeah. So this is the LED complete stent, and this is the final angiographic shot. Can you show the final angiographic shot? Next one. This is the leocaudal view. Next. No, previous. Yeah. And this is the final shot with the LED. I think it looks fine with us, but any comments, we'll be happy to take it.
Great, congratulations on a very nice case. What were your final contrast and radiation numbers?
Final contrast was 150 and the radiation is 9391.
So almost 10 gray.
Yeah.
Okay.
So I think that part is still, we are way behind in India. We are not using those radiation protecting covers
Right.
because of the cost perhaps, but yes, that's in discussion now, and that may be the case in every case further on in, with the discussion with the management, yeah.
A very, very nice coronary result, probably worth following the patient up post-operatively in 6 to 8 weeks to make sure that the skin is healing, and I look forward to understanding what a repeat echo would look like in him to see with better flow down the LED whether or not that anterior wall wakes up.
Yeah,
I think that's an excellent result. I would say that you should extend the follow-up for radiation injury beyond the 6 weeks. So you do it at 6 weeks and then make sure for at least a year that you follow the patient periodically and that you avoid any non-critical any more procedures.
Right.
Yeah.
Right.
There's if you're absolutely pushed in the setting of STEMI or something along those lines, learned this from Dimitri, you can take a rad pad, cut it out, and place it over the area where you radiated previously so that you don't radiate over that area and then choose a different angle. But I think at 9.39 gray, I think it would be important to avoid any additional procedure. Certainly staging that ramus, these kinds of things would not be a procedure you would do for the foreseeable future while this patient's skin declares itself.
Right, well taken, yeah.
Thank you very much.
Yeah, great to be here. Thank
Congratulations
you.
on an excellent result.
Thank you from all of us, from Medanta. Thank you.
Congratulations. Thank you for having us.
Congratulations on an excellent result.
Thank you. Bye.
Greetings from FACS Foundation and TCT India South Asia 2021. This live case learnings is regarding the management of a multivessel PCI in ACS and post-MI scenarios, which was demonstrated by Dr.Rajneesh Kapoor from Medanta Hospital, Delhi. In this acute coronary syndrome and recent anterior wall MI patient with LV dysfunction, EF 25%, the RC had a tight proximal disease which was very focal. LAD had a osteal disease extending to the mid-segment and followed by subtotal occlusion with faint feeling. And the LCX had a tight disease proximally, and the OM was also involved. So it was discussed whether to tackle how to prepare these patients well for the procedure, and it was highlighted to prepare, deconstruct the patient well, assess their PA pressures if required, and to have hemodynamic support available was discussed. And then probably in our country, because of cost constraints, we can't afford to have protected PCI with impeller or other things. But it was thought that we should do a quick job and try to optimize the results and not produce trouble in non-infarcted vessels. This aspect was discussed well. And then whether to tackle the infarcted related LAD first or open up a non-infarcted straightforward looking vessel in the RCA was discussed. And because RCA lesion was type A and very focal, and LAD was occluded, so it was decided to tackle the RCA proximal lesion first, and as expected it was stented without much of problem. Then before tackling the LAD ostium, it was thought to tackle the ostial LCX as well as bifurcation of LCX, because if you, while placing the ostial LAD, if stents could sometimes obstruct the passage of stents into the LCX was highlighted, and that's how the LCX was tackled. The effectively OM and LCX was done with a 2-stent technique of mini tap or mini crush, what do you call. And then later on with image guidance, the proximal portion of the stent in the proximal LCX, proximal to the OM origin, was again effectively post-dilated with a bigger sized balloon after assessing the diameter of the vessel in the OCT, which was quite big. And later on, after the OM LCX bifurcation was done, then effectively the ostial LAD and then the mid LAD was opened up with the balloon initially, and then with a longer stent of 2.75 diameter, because distal vessel was small, was used, and then the proximal vessel was dilated with a bigger sized 3 mm balloon with high pressure inflations, and finally OCT was done to demonstrate the ostium of the LAD is just covered without much of protrusion into left main. And it was also discussed whenever such lesions involve the distal left main, you could do crossover stenting also. And then, but here, because left main was totally free from disease, and effectively it was tackled only by optimal placement of ostial stent from LAD, and the final result was good. The point of concern was such long procedures do take a lot of contrast and radiation, and in this patient the radiation dose which was calculated went up to 9 grays plus. So it was thought that what is optimal is less than 5 grays, and this patient, if he requires some other procedure in future, it is preferable to avoid for at least 3 to 6 months. And then usage of radiation protection devices like rad pads, and probably we all becoming more conscious about the radiation were also highlighted by Dr. Dimitri, who was moderating the case along with Dr. Sanjog Kalra. The points of discussion and then points of contention of tackling culprit vessel first or the non-culprit straightforward lesion first were also highlighted. And as a general rule, we tend to tackle the infarct vessel first, but there could be some exceptions like this where patient had severe renal dysfunction, and then probably other critical lesions could also become ischemic. That's how this was supported. But all of us should weigh the pros and balance of these each, and then try to do good to these patients. And careful monitoring of patients' hemodynamics and saturation during such complicated procedures, especially in ACS scenarios, is very well highlighted, and the final result was appreciated by all. Thank you. Hope you enjoyed this live case of multivessel PCI in acute coronary syndrome and post-MI scenarios. Thank you.